Linda Maxwell. I'm a physical therapist and an MECFS patient.
And I'm Sally Rudisky. I'm a retired physical therapist and an MECFS patient.
Sally and I met online in MECFS patient Facebook groups. And the one thing that we heard over and over again from members of the groups were that when they tried to do physical therapy, not only was it unsuccessful or not helpful, many of the times they actually got worse. Sally and I were very disheartened by this, so we came together and we co-founded a Facebook group. And the Facebook group is for physical and occupational therapists and assistants to teach them about the unique characteristics of MECFS and what makes it different from a lot of other conditions that they're used to working with. Working with an MECFS patient really requires a paradigm shift in the thinking on the therapist's part. And so we go over a lot of the scientific-based literature that documents things such as how the cardiovascular system is affected. We wanted to empower therapists to be able to work with patients and to be confident that they could work with them without harming them. It also, we teach the therapist that most likely, if your MECFS patient is well-versed, then they're actually going to know more about your disease, the disease that they have, than the therapist does. And that's okay, because what most patients want that we've seen is someone who's willing to learn and someone who's willing to listen. And so if you're a patient, we really encourage you to communicate how you're feeling and what your goals are for working with the therapist, and to trust your body and to let them know if something is not working. So what exactly is physical therapy? We hear the term a lot, and most people just think physical therapy is exercise, but really exercise is just a part of a bigger picture. So the definition: therapy for the preservation, enhancement, or restoration of movement and physical function that is impaired or threatened by disease, injury, or disability that utilizes therapeutic exercise, physical modalities such as massage and electrotherapy, assistive devices, and patient education and training. And physical therapy is also called physiotherapy in other countries besides the US. What's really important when thinking about physical therapy and working with the MECFS population is the term function. We really want to work with the patient to enhance their functional abilities through their daily activities and measure that based on how they're able to function within the day and make sure that we don't cause harm so they actually will get worse. And the other thing to consider when we talk about therapeutic exercise in terms of physical therapy and MECFS, any activity that a patient does is really exercise in their day. Exercise, I think a lot of people hear the term and they're like, I don't want to do exercise, or exercise makes me worse. And we understand that. And so in our minds, exercise includes and really is all about activities of daily living.
So physical therapy is not just exercise, as Melinda said. Physical therapy, in many cases in the general population and in healthcare providers outside of the physical therapy practice, is considered just exercise specialists. They're believed to be practitioners of exercise therapy only. Even there are physical therapists who practice almost exclusively in the realm of exercise, using very few other modalities of treatment. But as you can see here, this is a list of a variety of modalities that physical therapists are trained in and specialize in across venues of practice. There are asterisks beside several of them, and those represent specific treatments or treatment modalities that have been anecdotally spoken highly of in the MECFS community, or the benefits of those treatments for reducing patient symptoms. It's important to know that there is no FDA-approved treatment for MECFS, and PTs and OTs have a great opportunity to help improve the patient quality of life by using modalities in a way to reduce symptoms. So these are what modalities are used for, is symptom management.
This is one of the slides that we use in our Facebook group to educate the physical and occupational therapy. So we're always talking about graded exercise therapy in the MECFS community and the danger of graded exercise therapy. But what exactly is graded exercise therapy? Graded exercise therapy, or GET as it's commonly known, is a predetermined increase in frequency, duration, and intensity of an activity despite symptoms. And that is where an MECFS patient will really get into trouble. So we really try to, this is where the paradigm shift really needs to occur in a therapist's thinking when working with an MECFS patient, that they are not going to be able to do traditional exercises like they're trained in school. They're going to have to change some things around so that the patient can actually benefit and not be harmed. And I have therapists ask me all the time, you say no GET, you say no GET, you know, why so negative? And I tell them two things. First of all, it's really important that you understand graded exercise therapy with MECFS and the history, because there is a long history of damage with graded exercise therapy. It's based on the disproven idea that the problem in MECFS is caused by deconditioning. And we know scientifically that that is not what's happening with these patients. We also stress the importance of not triggering post-exertional malaise, also known as PEM, which Amy will talk about in a lot greater detail. If you ever want to read about the history of graded exercise therapy in MECFS, Julie Raymeyer has an excellent article that she wrote about the history. It wasn't until just last year in 2021 that graded exercise therapy was removed from the NICE guidelines in the UK as the recommended treatment. It was based on the biopsychosocial model of MECFS, which has been disproven finally after lots and lots of advocacy from all over the world. And I tell therapists that when you look at something on the internet, it's there forever. So if they come across a study that's recommending graded exercise therapy, that doesn't mean that it should be done, you know, because it's out there, still out there, even though it's been proven to be harmful and shouldn't be used.
So physical therapists strive to practice from an evidence-based standpoint. And when selecting modality of treatment or modality of intervention to work with a patient, many therapists will seek out research to guide their practice and their selection. Here are some specific considerations when the therapist is making an evidence-based decision with MECFS patients. MECFS research often describes interventions only as physical therapy. So it's really important to understand what modality has been utilized. Is it exercise or is it something else? Is it something that is more patient tolerable or less patient tolerable? If it is exercise, what kind of exercise is it? The second thing that happens often with MECFS research including physical therapy is that the diagnostic criteria often used in the research may be too broad to be useful. Older diagnostic criteria was so broad that it often included individuals who had primary depression and other fatiguing illnesses. More current diagnostic criteria is more specific, and it also includes the key or the hallmark feature of post-exertional malaise. Research that does not include assessing the patient's tolerance to the experimental intervention with their response to post-exertional malaise is pretty useless, since this is the key feature to the illness. Thirdly, what does the evidence apply to? Who does the evidence apply to? MECFS is a very, very heterogeneous illness. You have a wide spectral display between mild and very severe. There are many comorbidities that overlap, and there are subsets within the illness itself. So if the research doesn't specifically state who is being studied, then assumptions cannot be made that that modality is safe or effective across the patient spectrum. And the risk-benefit must be considered with great care when using that to make a decision with the patient. Fourthly, does the research show if and what MECFS subjects had to give up in exchange for participating in the study? So if a patient participates successfully in an intervention that is being tested, but has to give up an ADL or an IADL to be able to be successful in that experimental procedure, then is it really worth it? Was it reported in the conclusions and in the experimental results? Fifth, as Melinda said, no get with MECFS patients. All interventions should be flexible and symptom driven. Sixth, once something is on the internet, as Melinda said, it's out there, and it does not mean that it's factual, legitimate, or current. It's the duty of the healthcare provider to practice with both beneficence and non-malfeasance. Beneficence is to do good, and non-malfeasance is to do no harm. Failure to practice with these two concepts in mind is avoiding the scientific consensus and is putting your patients at risk. Now back to Amy.